So I'll briefly try and go through the history and evolution of navigation systems over the next 5 to 7 minutes. So no disclosures and no conflict of interest. So in one slide, what is navigation? It's a computer assisted surgery. It's a technology that merges preoperative imaging with intraoperative imaging so that you can see unseen anatomy. All this helps is for you to 3D visualize in real time during surgery where the screw is going, how your instruments are going, with the ultimate aim to improve the safety and accuracy. So if you look at the origin of navigation, it probably is related to neurosurgery, where you had stereotactic brain surgery. Frames were attached to the skull for deep-seated brain lesions. The difference between spine and brain here is between the skin and the skull, there's not any mobile unit, and it's very close by. So in spine, it got more complex to begin with because there is considerable soft tissue between the skin and the bone, and inherently the spine is more mobile. The need for navigation in spine, I think, arose more after the segmental fixation techniques, which we are now using practically everywhere from the pelvis all the way to the occiput. So navigation was required to help ease the insertion of such implants and to do them safely without harming any vital structures. So broadly speaking, navigation can be considered under two headings. One would be fluoroscopy-based navigation, which had two-dimensional navigation and three-dimensional navigation. And the other would be considering it under CT-based navigation, and depending when you did the CT, it could be a preoperative CT-based navigation or intraoperative. In the truest sense, there are 5 basic steps to navigation. You have to acquire an image, you have to plan your surgery. There is a process of registration of the patient inside the OR. Then you have a computer-based algorithm which connects the two, the imaging acquisition acquired and the registration performed. And then you go ahead and place your implants and guide implant placement with the algorithm that's generated. The two cornerstones in this are the image acquisition and registration. And based on how the image was acquired and how registration was performed, the evolution and history of navigation can be understood better, because this evolution happened over the change of image acquisition and registration. So for practical purposes, it can be considered under 3 generations. First generation navigations were the first one which used preoperative CT scans. Second generation navigation moved on to fluoroscopy based, which had 2-dimensional and 3-dimensional imaging. And then eventually we have gone to a third generation where we are using either intraoperative CT based navigation. So this all started somewhere in the mid 1990s. In terms of spine navigation, I think pioneers there were a couple of groups, one in France by Merlot. The paper was published with Clinical Orthopaedics and Research in 1998, and the other gentleman being Dr. Nolte in the United States. So this first generation had imaging acquisition was through a preoperative CT. The registration was tedious because it was manual by surface marking and point matching. The supine CT was done preoperatively and the patient intraop was prone. So there used to be some difficulty in change in position. And as you had to expose most of the spine to match each of those 5 to 8 points, doing a minimal access surgery with first generation navigation was difficult. Additionally, any intraoperative movement would lead to loss of fidelity, and the entire process of matching or registration might have to be repeated. If you look at the image, you can see most of the handheld instruments with the light emitting diode had actually cables that need to be attached to the computer. So it was that way tedious. And additionally, just have a look at what type of computer systems they were working at. They had a hard disk memory of 1 GB and a random access memory of 64. Most common day phones have much more than this. So quickly through the workstation. So I get a preoperative imaging in the form of a CT. I plan which levels I would like to instrument. Once this is done on the intraoperative, quite often for one level, you would have to match between 5 to 8 points. Once you had the matching done, you would then move to patient registration. If there was any loss in fidelity, you would have had to rematch and re-register. Once patient registration was confirmed, you would then perform a verification of accuracy and then proceed to insert your implants. And also, you need to repeat all these steps for each level that you would instrument. What changed with second generation was it was fluoroscopy based. By now, fluoroscopy was used regularly in the operation theater in terms of biplanar imaging, which would be AP and lateral shoots. From this fluoroscopy, we moved to image acquisition intraoperatively using the same fluoroscope. The registration was automatic, but the drawbacks were this was a two-dimensional image. The image that you finally did the navigation on was also poor quality C-arm images, and the advantage being that it was done intraoperatively, so the patient position during the scan and when you were operating is the same, so that was one advantage. But eventually the concerns were that the image quality was not as good as a C-arm. So consider an example like this. This is the image of a lumbar spine lower segment. So the white arrows show the reference electrode, which reference array, which is probably inserted over the, in this case, at the L2 spinous process. But what you can see is practically only 2 or 3 spine segments. So the field view was quite restricted. You could not consider operation on major spinal deformities because multiple such scans would have to be done and radiation exposure would increase. Also, because it was a C-arm image, patient habitus such as more obesity or even difficult to view see regions of the spine such as cervicothoracic junction were difficult to use with second generation navigation of 2D fluoroscopy. This would be an example of the final image that the navigation would have. So you can see the image quality was not as good as you would expect. What changed in the second generation somewhere was the development of a cone beam CT technology, where the regular C-arm would move from 0 degrees to sometimes up to 180 degrees and shoot multiple X-ray shoots. These would then be reformatted to give CT-like images, though not conventional CT clear, but at least much better than regular C-arm images. So in this sense, the image acquisition was through fluoroscopy, which was again intra-op, but registration also was automatic. The front runner of this was the ISO-C and its variants, and thus was born the three-dimensional fluoroscopy-based imaging, in which the additional axial component of the viewing was available during real-time intra-op navigation. The image quality obviously was better than a 2D, and also it was considered better for obese or even complex regions such as cervicothoracic junction. Just a slide on cone beam CT. So basically you would go from 0 to 180 degrees and take shoots. So unlike biplanar, which was 90 degrees or perpendicular to one another, where you had an AP and lateral, here you would go from 0 to 180 and multiple such images would be reformatted to get you something like this. So this is what the ISO-C was based on. It was a fluoroscopy based navigation, but the final images appeared CT-like. The advantage was you could place the reference array through a minimal access portal on a particular landmark on the spine, and as a result you were able to perform some minimal access surgery, unlike generation 1 where you need to do manual matching and you need everything exposed from transverse process to transverse process on either side. The drawbacks for this, again, because it is based on a C-arm, the field of view when it goes through 0 to 180 degrees often can span maybe 5 cervical levels, maybe 3 to 4 lumbar levels. So again, if you had a longer segment to fix, you might need to repeat such scans, as a result increasing the radiation exposure, and also need extra time for such scans. Finally, we come to what is now current status. We have the third generation scans. So here image acquisition is intra-op, registration is automatic. The OARM 2 that that we are all using currently, even Dr. Bharat Dave is using, is one step higher than the conventional 3D fluoroscopy, in the sense it has a 360-degree rotation. So the final images that you get are quite like CT, and there is very little difference than a conventional 32 slice CT that you would otherwise get maybe at any of your hospitals. The flat panel detectors on the OARM improve the scan view, so you get 20 centimeters of vision, so you get a larger segment which you can scan. And obviously the OARM also has the additional advantage of image stacking, where 20 and 20 could add up to 40, which generally means that you don't need to quite often repeat a scan in case you do have a long segment to instrument. Additionally, modern day navigation have light emitting diodes over all the handheld instruments. It can go from as simple as your ball probes to your sounds to the drills to your taps, and as a result you can see the position of all your instruments, not just the final screws that are placed. And to complete what we have, the leading or the state of the art would be intraoperative CT, which is basically a portable CT scanner. It's not a 128 slice, but it's a 32 slice scanner, which is seen in the Aiyer and the body tom. This unit can be placed in the OR. It is quite often portable and can be moved from OR to OR. The only downside is obviously the cost. There are certain issues like separate tables is required, because not a regular table will fit into the gantry of such CTs. Additionally, this intraoperative CT give you good soft tissue details, so maybe of usefulness to neurosurgery, not particularly to spine surgeons or orthopedic surgeons like us, but yes, it has some additional benefits. So just the final slide, a summary. So point matching, the big problem of preoperative CT, not possible to do minimal invasive, which improved with the others. But the problem was that there was imaging was lower quality in fluoroscopy. It improved with the cone beam, and to current state of the art is an intraoperative portable scanner, which is the current best available technology in terms of intraoperative navigation. So thank you for your time. I hope I'm hoping that I've covered everything quickly as possible and not making it too boring in terms of a history lecture.